No, I can't. I cannot hear you. I can.
Can you hear me now?
Yeah, yes. Great.
Okay, thanks.
Okay. So just wait a few minutes.
Sure.
So it's not 12 yet.
Sure.
Okay.
Shigan,
Yes.
it's Mark.
Hey, how are you?
Okay, I'm just telling you, I'm gonna unmute myself.
Good. So we will start in probably like 1 or 2 minutes.
Okay.
So we will have the chance to discuss.
Yeah, we'll see. I don't know how long. I won't stay the whole time, but I'm here.
Okay. Thank you so much. Thank you so much for your support.
Okay.
So I guess maybe we can start. So if you don't mind, you can. So we
Yeah.
can wait because they can just join automatically. Last times I choose the wrong setting, so now they can join automatically. All right. So thanks everyone for your join the meeting. So this is our second seminar for 2020 and 2021. And today, so we are very pleased to have Dr. Yikai from University of Essex, and he's going to talk about testing for COVID-19. So interesting, so this idea, so actually he had this idea or advocate this idea a few weeks before, it's Romer, right? Paul Romer. Paul Romer also had a similar discussion in another conference. So Yikai is going to talk about what is optimal testing for COVID-19 and why it is relevant. And thank you so much. And floor is yours. So just a quick explanation of the rules. So normally, so we are going to have 1 hour presentation, and then so we are going to have 10 to 15 minutes discussion. So for the audience, so they may send you questions in the middle, right? Yeah. Thank you so much. The floor is yours.
Okay. Great. Thanks so much for having me here. It's my pleasure to be here to present my work on COVID-19. So if you can stop screen sharing, then I can share the screen. Okay, thank you. Okay, so as Zhigang mentioned, I kind of started writing a simple paper and present how testing could help suppress the disease, and a bit earlier in the first outbreak. And now I think the topic is still relevant because a lot part of Europe and all of the world are facing the risk of the second wave. And then I think you will see that testing can be quite helpful in terms of fighting the first outbreak. And it could also be kind of useful when we are trying to prevent a second wave or prevent a large outbreak. So I'm mainly going to use examples and data from Nordic countries and Europe, and also a model to discuss the impacts of testing on the disease spread. Okay, so there are a lot of policies that are implemented to fight the COVID-19 disease. Of course, if we have very good hygiene, it's definitely helpful to slow down the disease spread. And we also have very strict policies, sometimes on social distancing and lockdown, that are also very effective but quite costly. And testing is kind of a policy that is not that costly, but of course subject to the capacity. So there are debates on whether we should increase or decrease testing. So one role of testing is to provide more information, not only for the doctors, but also for the public and policymakers. And this role is debated by many people because you can find that definitely there are benefits of providing more information, but people are also worried about creating panic and other kind of issues of providing information not very efficiently. And there's actually a second role of testing, which is what I'm going to emphasize, which is that testing can slow down the disease spread. It can reduce the reproduction rate of the disease. I'm going to be more specific a bit later, but intuitively you can imagine if you test an infected individual kind of quickly and in the early stage of the disease, of the infection, and this person kind of stayed home or quarantined, and then the infection that this person is going to create can be much lower than if this person was not tested. And of course, if the testing result came out very late, then it's probably not very helpful. And as I said, I'm going to use a bit examples and data from Nordic countries and Europe to support my model. So why do I focus on Nordic countries? Well, because fighting COVID-19 is a very complicated issue. Different countries have different policies. They have very different economic, cultural, and social backgrounds. And Nordic countries, they have kind of very similar economic and social conditions. They are all developed countries, and culturally, they're also very similar. But somehow they have a huge variation in terms of policies on how to fight COVID-19. So we have seen Iceland, who started large-scale testing from late February. We see Norway and actually Denmark and Finland also similar. They limit testing in the beginning, but they start to increase testing in the mid March when they see examples from Iceland and when they realize benefits of increasing testing. And of course, Sweden follows a very different road because it kind of limit testing throughout the first outbreak, I think until June. But recently, this also started to catch up. And also, they have other huge variations in other type of policies on whether they should lock down, when to lock down, whether they should forbid traveling. That's also quite interesting. But in this talk, I'm kind of focused on testing. And I think the second reason of focusing on Nordic countries is that they provide some kind of success stories. I mean, we are still fighting COVID-19, so what's going to happen in the future is not clear. But in the first stage and in certain area at around, they have provided some successful cases with slow spread, low mortality rate, and not crowded hospitals, for example. And those successes in Nordic countries, kind of, as I said before, are achieved with different policies. So it's kind of interesting to look into them. So let me first start with a few anecdotal examples in Norway and Iceland, and then we're going to see a bit more data and a bit more systematically organized model and regression. So what happened in Norway is that in the beginning, they start limit testing. On the one hand, it's because the testing capacity is limited. And on the other hand, it's because they are worried about the panic of the public. So they are hoping, given the experience of fighting swine flu and other diseases, if you just limit testing, only test those people who have severe symptoms, then you don't create panic. There's definitely this benefit of limiting testing, but what happened is that the cost of the limiting testing kind of dominates the benefit. You see a very rapid increase of infections from people who should be tested but were not tested. So the example is that the Norway strategies, we're only going to test people who came from northern Italy because that's the hotspot of COVID disease. So people who went to the famous Austrian ski resort near Italy were not allowed to be tested. So there were people who went there and came back with a lot of symptoms and even difficulty in breathing, but because the policy is that we have to limit testing to those people who have symptoms and went to the risky area. So those people who went to Austria will not get tested. So they kind of still, the skiers, they are very active and very social. So they're still living their active social life like before. They spread the disease very fast. Finally, in the March, there was one guy who came back from Austria and he really wanted to be tested. He tried to apply and he was declined many times. At some point, he decided to lie. He said, okay, I actually traveled to Italy. And then he got tested. And they found that this guy was positive, and then they start to realize those people who came back from Austria may also carry the disease, but because of the limiting testing policy, they were not tested. So what happened is that in the mid-March, you see there are more cases originated from Austria, 377, than from Italy. Actually, more than the cases from all other countries combined. The funny thing is that there are actually more cases originated from Austria in Norway than the number of cases in Austria. Okay? So that's why there's a small group of people without being tested, and then they spread the disease really, really fast. And then in Iceland, they took a different approach because they in the beginning, in the early March, they already tested Icelander who traveled to Austria ski resort and found that he was infected, and then they defined the Austria ski resort also as a high risk area and started testing people who came back from Austria. Actually, they started large scale testing that covers a lot of people who have symptoms or find that they maybe carry the disease without having to satisfy these very strict rules of getting tested. So what you can see from this figure is that the number of testing per 1,000 people in Iceland is just very high. As you can see, the blue line showed that Iceland tests much more than Norway, and Norway also tests much more than Sweden. So, and of course, if you test more, you find more cases. That's exactly what happened in Iceland. So you find much more cases in Iceland, which the purple line shows until April. And Norway find less people because they don't test much. Sweden find the least because they didn't, they limit, as you see from previous figure, the number of tests in Sweden is even also a scale lower than Norway. So, but the nice thing is that when you find a lot of cases, as you see in Iceland, the spread of the disease also slows down very fast. So you can see the number of cases drops really, really fast in Iceland since April. And in Sweden, even though in the beginning you find less cases, but the number of cases keeps increasing. And Norway is somewhere between, and Denmark and Finland are similar to Norway, so I didn't show the data in Denmark and Finland. But the number of cases that you find when you test more is higher, but it doesn't mean that the real number of cases in the society is higher. So if you look at the number of people in hospital, so remember we find that much more number of cases in Iceland than in Sweden. But if you look at the number of people in hospital, Iceland actually has much less people in hospital and much less people in intensive care with respiratory machine and other intensive care. And you see the number of people who are in intensive care and in hospital drops very fast in Iceland. And the number of people who are in hospital and intensive care in Sweden keeps rising. It goes down very, very slowly. So if we look at the number of deaths, what happens is also, the number of deaths kind of reflects the real number of people who are infected. But of course, it was also affected by how healthy people are, but perhaps Swedish Iceland and Norwegians are similarly healthy. But it also reflects how crowded the hospital are, how scarce the medical resource is compared to the number of people who are infected. But the number of deaths in Iceland, as you can see, are much lower than in Sweden, even though in Iceland they find much more cases in April. So from this figure, like what one can guess is that testing kind of slows down the disease spread. As I offered in the beginning as an intuition, people who tested positive, if I'm an Austria skier who tested positive, I stay home. If I did not get tested, I'm going to social a lot and spread the disease. And then the question is that, can testing slow down the disease spread long enough to prevent herd immunity? So, because one concern that Sweden has is that, okay, Norway, Iceland, you fight with the COVID-19 disease very hard in the beginning, you test a lot, but later we are all going to end up in herd immunity. So what you did in the beginning was not useful at all. But we can think if the testing can slow down the disease spread long enough, maybe we can kind of end up not having herd immunity, at least until we have the vaccine. And I also want to talk a bit about the cost and efficiency of testing, and also think about the relation between testing and other policies such as lockdown. Are they complementary, or do they substitute each other? So I wrote a very simple analytical SIR model of epidemics, and I introduced testing into that. So I'm going to be kind of quick in those explaining the model. I'm just going to talk about the simple part of the model. But if you're interested, you can read the paper in my web page. And then, so in the model there are infinite periods. It's a discrete time model, and then each period represents the infectious period of the disease. So in the model, which is 2 weeks or 10 days, so one person gets infected, and this person is going to be infectious, and she will or he will probably spread the disease to some other people. And this is one period in our model. So that makes the discrete time model much simpler than the continuous time. So I can see that there is a question saying that the cost and effectiveness of testing changes over time. Yes, that's true. That's a good point. So that's why we need a dynamic model. So the cost and effectiveness of testing definitely change over time, depending on how many people are infected, right? So I'm gonna go into a bit more details, but one can imagine that if you test early when there are not so many people infected, and slow down the disease spread so that the number of infected people does not increase, then the cost of testing can be relatively low, right? If you think about Iceland, they start testing a lot of people, but that was in the early stage of the disease spread. So still it's just a very few amount of people who are infected. So at that time, when you want to use testing to reduce the disease spread or the reproduction rate of the disease to below 1, you just need to test, I don't know, 1,000 people per day, okay? And then the cost is low. But of course, if the disease is already widespread and there's thousands of people, millions of people infected, and then you start using testing to reduce the reproduction rate of the disease, the cost is going to be much higher. And of course, the cost and efficiency of testing also depends on what other policies are implemented. So they are probably complementary or substitutable to each other. And then that's also interesting, which I hope I can explain a bit more later. Okay. So the key for the disease spread in the model is the number of infectious contacts, which can be reduced using social distancing. Okay. So if one person contact with beta persons, then an infected individual is going to spread the disease to beta other individuals. And what I introduce in this model is testing, which provides information to the infected individual. So if an infected individual were tested positive, then he or she is going to decrease the contacts. So it could come from voluntarily staying at home. It could come from government policies that force people to stay at home when they are tested positive. So in any case, if a person who's tested positive, he or she is going to reduce the contact rate from beta upper bar, which is how many people I contact if I'm not tested positive, to beta lower bar. And as you can imagine here, we can think about other policies such as lockdown that reduces beta upper bar and strict quarantine rule that reduces beta lower bar, and all those kind of other policies are going to matter. But what I'm going to focus on in this model is P, the fraction of infected people who are tested. So we can imagine that if P fraction of infected people are tested, then the infectious contact beta is going to be P multiplied by beta lower bar plus 1 minus P. That's a fraction of infected people who are not tested multiplied by beta upper bar. So it can be lower. So the majority of the people in the society are still contacting like normal beta upper bar, of which could be reduced by lockdown. But the infectious people, the target group, because of testing, reduce the small group infectious people's contact rate. So there's another question, I think. Right, so it's about targeted testing, testing health workers. That's true. So that's an interesting and important question. But I'm not going to talk about that in my benchmark model. But definitely, we can extend this model or use the way of thinking to think about that, because we can think the health workers, they are perhaps more important, or they are perhaps going to meet more people, right? So I didn't introduce heterogeneity in this beta upper bar, but you can imagine if health workers, they are in contact with many more people, their beta upper bar is going to be higher. Then increasing P in my model reduces 1 minus P multiplied by beta upper bar quite a lot for those group of people whose beta upper bar high. Then targeting testing on those group of people makes sense. But I don't have that in my benchmark model, but that's definitely an interesting question that we can consider. If we just think about testing the health workers to slow down the disease spread. But of course, health workers are also kind of play more important role during the time of the COVID-19. So there are also other reasons to to test health workers a bit more. But definitely in terms of disease spread, this model can be extended to take into account that. So this is kind of perhaps standard in the SIM model. So I'm gonna go through it a bit quick, but if you have questions, just stop me. So the reproduction number in those SIM model is the number of new infections that each infected individual produces. So we see before the number of contacts that an infected individual contact with is P beta lower bar plus 1 minus P beta upper bar. And of course, an infected individual may contact people who have already been infected, and they are only going to spread the disease, create infections to those people who are susceptible. So let's denote the fraction of the people who are susceptible as beta. Then each infected individual is going to meet with beta S susceptible individuals and create beta S new infections. The rest of people she meet with or he meet with 1 minus S multiplied by beta are already infected, have been already infected before, so that they are not going to create new infections. So this beta S is the reproduction rate of the disease, which is denoted as R in the literature. It also represents the growth rate of active infections in this discrete time model. So we know that the basic reproduction rate of COVID-19, which was referred as R naught, is usually 2.5. It can be actually higher, but this corresponds to the beginning of the disease spread where there are not enough testing. P is almost 0, and everyone is susceptible. So we can imagine beta upper bar is probably around 2.5. So, and then if we want to contain the disease, to have a decreasing number of infections without reaching herd immunity, so what we need is that this R is smaller than 1, right? We said that's the reproduction rate of the disease, that's the growth rate of infections. If the growth rate is smaller than 1, then we kind of contain the disease. We're going to see the number of infections decreases over time. Of course, it can be slow or fast, right? If R is significantly lower than 1, you're going to see a very fast decline as we see in Iceland, but it could also be slowly declining if R is smaller than 1 but close to 1 as we see in Sweden. So, of course, one way is to reduce this beta, reduce the number of infectious diseases, infectious contacts using lockdown or testing. But even if we don't reduce beta, when the number of susceptible population goes down sufficiently low, so if it's smaller than 1 over beta, then beta S is going to be smaller than 1. There's going to be, if there is a lot of immune population, then the reproduction rate is going to be smaller than 1 anyway. So that's a so-called herd immunity. And if we don't want to reach herd immunity, then we need to make beta smaller than 1. When we have beta smaller than 1, independent of the number of susceptible people, without having a lot of people infected, we can end up having R smaller than 1. So we could use lockdown to reduce beta upper bar, which is kind of costly, but we could use testing to reduce beta without changing beta upper bar, right? So a simple calculation shows that if P is greater than beta upper bar minus 1 divided by beta upper bar minus beta lower bar, then beta is going to be smaller than 1. The reproduction rate can be smaller than 1, even though the number of immune people is 0. Without herd immunity or vaccine, we can achieve that, kind of what people see in Iceland. And as I mentioned before, when the number of people who are infected is low, testing can be less costly. So you don't, if there are just a few thousand people infected, like in Iceland, you test a few thousand people, and then you are able to reduce beta and R. There's another question. Let me see if I can find it. Okay, great. So the question is about the fixed cost. The fixed cost of testing can be quite high, and that is true. So the capacity of testing is a constraint for a lot of government. And of course, almost every government can decide lockdown. But I think in most cases, the entry cost of testing might not be higher than lockdown, because if the government is aware of the benefits of testing, like in Iceland, they can or Germany, and also in, for example, Korea, you can very quickly build up the test capacity. And of course, if there are complicated issues that makes this impossible, then the entry cost of testing is quite high. I agree with that. Another relevant point is that now we are coming to the second stage, or the second wave. It's already half a year before the first outbreak. So the capacity constraint of testing was more severe in the first outbreak, and now that entry cost or capacity constraint is probably not a huge issue for most developed countries and many developing countries. So that's why I think there's actually more space or potential to use testing to reduce the disease spread and prevent a new outbreak. Thanks for the question. And then, okay, so that's we can see that testing can be used to reduce the disease spread, reduce the reproduction rate of R to below 1, and kind of prevent herd immunity. And of course, we can take this model and do some experiment. If there's no control, as you can see, the blue dashed line showed that you can have a very fast disease spread, and the disease will gradually die out because of herd immunity. But if we try to test a lot and find 20% of people, or 50% people, or 70% of people. So this is based on some model parameters that I assume, such as the key is that the beta upper bar is equal to 2.5, and I set beta lower bar to 0.5. And so in this case, we can see when we test more people, when testing is not sufficient enough, P is equal to 0.2, we cannot prevent herd immunity. We're still going to end up in herd immunity. A lot of people are going to be infected, and the disease will die out. But you can see that from the lower subpanel, the number of people infected eventually, or the number of people that herd immunity requires, can be much lower when we keep testing people, okay, compared to the blue dashed line saying more than 80% of people will be infected eventually. If we can test and find 20% of people who are infected on time, we're going to end up having a bit less people infected. If we have 50% of people found out when they are infected, we have much less. If we find 70% of people infected, it can be basically, we can avoid herd immunity. We can have a very long time without outbreak until the vaccine came out. And of course, we could also use lockdown. So if we only use lockdown, it's probably not going to be very effective. That's the so-called public fatigue, saying that in the benchmark which the blue line shows, if we take no control, it's like this. The red line shows that if we lock down very early, but it's temporary because over time people are going to resume their normal life, you kind of delay the disease spread, but you are still going to have this peak and have a huge amount of people infected, basically the same amount of people infected in the end. So that's what the Sweden was worrying about. You can fight a lot in the beginning, but in the end, you're going to end up in the same situation. But of course, if lockdown is done long enough, like the purple line shows, you can end up having less people, but that's going to be hugely costly because you're basically going to impose lockdown forever, and you're still going to end up having a lot of people infected in the end. And in the paper, I also show a figure that if you kind of combine lockdown with testing, that for the sake of the time of the presentation, I skip it. You can actually if you have testing, it's kind of complementary to lockdown. As you can see from here, if you test a lot of people and you have a little bit lockdown in the beginning when the outbreak came out, you can very quickly reduce beta to below 1 and reduce the slow down the spread of the disease very fast. And later, when you really relax lockdown but keep testing, then you're going to end up having much less people infected. But if you don't use lockdown when there's a huge outbreak, you only use testing, then the number of cases are going to slowly go down. Eventually, you may have a bit more people infected than you use testing, but lockdown in a huge outbreak, but relax lockdown when the outbreak is over. Okay. So there's a question about the use of mask and use positive rate. Yes, definitely. So I think the use of mask in the model is definitely important. It kind of speaks about an effective policy that reduces beta upper bar, right? So I don't talk about this because in Nordic countries, they didn't do that. So Denmark, at some point, were thinking about asking people to use masks. And then they even did some experiment in April, let a few thousand people wear masks and a few thousand people not wearing masks and see what happens in the end. That because of their testing and lockdown policy, the number of cases went down very fast in April, so that experiment actually in the end it didn't work. But the Nordic country didn't use that. Doesn't mean that other countries does not need to use that, because as you can see from this equation, the goal in the end is to reduce beta to below 1, right? So Nordic countries is probably a case where the beta upper bar is already very kind of low because of people cultural, and the population density. But of course, in large cities like Sweden and Oslo, population actually very dense. So in the end, they didn't use that. But if testing is not sufficient to reduce beta to below 1, or we are in an outbreak where a lot of people are infected and it's very important to quickly reduce the number of infections, then using masks, lockdowns, and other policies, as you can see, are kind of complementary to testing. So I think it depends a bit on cultures and countries. So when you have testing that successfully reduce beta to below 1, then you can relax a bit other policies. But when that's not sufficient, then other policies are definitely important. So using positive rate and raw number cases are actually quite important. So the positivity rate I didn't show in the figure, but I know that the positivity rate is definitely low in Iceland and much higher in Sweden in the first wave. And now in the second wave, the good news that when people are testing a lot, the positivity rate becomes much lower in Nordic countries than in the first wave. So in some cases, the number of cases looks quite high, but the positivity rate is low. So that makes people a bit assured about the second wave in Nordic countries. So there's also another question about health check apps. Is substitute good for tests? Or would it be complementary? So I think, in these models, the substitute and complementary are a kind of an interesting issue, because it depends on what we try to define. So if we try to define whether they are complementary or substitute to reduce beta, I think the health check apps and lockdowns, they are substitute for testing, right? Or testing a substitute for those policies, because we're just thinking about reducing beta. So what happens in Norway is that because they're testing a lot, they're already able to reduce beta to below 1. They're actually relaxing other policies. In the mid-April, they already stopped lockdown when they see the number of people in hospital decreases. And now they even have rules such as if you want to visit your child from abroad, then you don't have to stay in quarantine. So they all even relax the quarantine rule to take care of the kids and all those kind of things that they can relax. So that is, in a sense, in terms of reducing beta, those health check apps and other policies are substitute for testing. But an interesting case is that when we look at the number of infected people in the end, most of the policies become complementary. So as I said before, lockdown reducing beta upper bar is substitute for P when we think about beta. But when we think about the number of infected people in the herd immunity, we can see that it comes as 1 over beta. Okay, so imagine that we are having a policy, our beta is around 1, say 1.01. You have another policy that reduces beta from 1.01 to just below 1, say 0.99. Then the number of infected people in the end, or the herd immunity, is avoided. So number of people infected in the end drops to 0. So in that sense, those kind of policies in terms of reducing number of infected population are kind of complementary to testing. So I think generally I would say all those policies, when you have those reverse term, becomes complementary to testing. Yeah, that's a good point. Thanks for asking. So and I also did some simple regressions just to regress the number of infected people on testing in the outbreak, in the beginning of the outbreak, and the testing in the later stage, and also other policies as lockdown, using some simple data cross-country regression in Europe. And we're also doing some panel regressions and considering instrumental variables, but just some very quick cross-country regressions. We can see that the number, if we increase testing in the beginning, test 1, that is the number of tests that a country conduct in March, then there's going to be much less cases and much less deaths. And later, when the disease spread, when you don't test in the beginning, but you test later, like this is the number of tests you do in May and June, it doesn't really help. And actually, sometimes you find positive, it's a reverse causality because you didn't test in the beginning and the number of cases increase, you're forced to test a lot later. But those countries like Iceland, when they test a lot in the beginning, later they don't have to test because there are no people infected. And lockdown also has a positive impact because of reverse causality in this case. Okay. When there are much more severe case, and then the government has to impose lockdown. But in Iceland, they basically didn't have to, and the Norway relief lockdown very early. So and we're also thinking about considering to switch from correlation to causality, because what I showed you is just correlation. But of course, some people are saying, well, the number of tests that the country implemented is not exogenous, and then we're discussing maybe we can consider some exogenous variation that determine the policy. One interesting case is that in all those Nordic countries with a lot of testing, or the government decide to test a lot in the beginning, they're all female leaders. So we're thinking about using the exogenous government characteristics to instrument the number of tests and other policies. So basically, to conclude, in those data and the model, what I try to argue is that testing can change infected individuals' contexts, and therefore it can reduce the reproduction rate R and the growth rate of the infections. So if the reproduction rate R is reduced sufficiently to below 1, then the total number of infections can be reduced and herd immunity can be prevented. And it's kind of less costly than lockdown and other policies. And so it can be sustainable. So you can see that a lot of countries keeping testing quite a lot, and it's much less costly than lockdown. So the policy implication from this simple model is that, well, we can perhaps use testing to prevent the new outbreak. This is a very important concern because eventually we're going to relax the social distance policies, and people are going to resume to their normal life. And of course, people are still going to keep better hygiene as before, so we're going to change. But a lot of things are going to resume to what they were like before, going to school, contact with friends. So, and then testing can kind of slow down the disease spread. And when we are facing the second wave, it can be hopefully smoother than the first wave, right? So, and hopefully we can avoid lockdown and overcrowded hospital, because COVID-19 is a disease where when you have good care and good rest, enough medical resource, that can be, the survival rate can be much higher. And if we can have a smooth second wave where the hospitals are not crowded, even if a lot of people are still going to be infected, there's going to be much lower death rate. So if we look at the cases in Nordic countries, you can see that there's actually a second wave that came in late July and early August, when a lot of people resumed their normal life and travel within Europe. So even Iceland started to have many more cases, and the number of cases in Iceland and Norway start to catch up with Sweden. But what happens that we see in the second wave, as you can see from the right part of the figure, even though the number of cases in Iceland and Norway is already catching up with late March or the middle March, but the difference is that the speed of the increase of the disease is much slower than before, and more importantly, the number of people in hospital are much smaller than before. So even though they find a lot of people in Iceland and Norway, but actually the disease spread much slower, the hospital is not crowded. And if you look at the number of deaths, it's, even though the second wave has been there for like 2 months, it's actually not creating excessive deaths. And another interesting thing that Sweden also start to, even though in the first wave a lot of people died, but now in the second wave, with their testing capacity catching up, with people changing their behavior and keep good hygiene, they actually also end up having much less cases and much less people in hospital and deaths. Even though Sweden has very relaxed rules in terms of traveling or so lockdown and social distancing, but there's hope that we can have some kind of low-cost, sustainable policy that prevents the second wave from being like a huge outbreak in the first wave, but keep the hospital not crowded, keep the death rate low. Okay. That's what that's all of my talk. Thanks a lot for your questions.
All right, thank you so much. Can you guys hear me? Can you hear me?
Yeah.
Okay.
Yeah, I hear you.
Very good, very good. So I do have a few questions. So maybe let me just let my colleagues to ask your question, and then so I can just ask you my question later. So we have a few.
Sure.
Yeah. No. Okay. So okay. So and then so let me just start asking my question. So right. So the last question I ask is about. Let me see. So I wasn't very clear. So in the text because I did not want to interrupt you. So my question is, because I was saying, think about testing versus lockdown. So they have different costs. So actually, when I say cost, it's a cost to the government. And so last week, so we have Junior from Kansas City Fed, and he talked about something similar. And then there's interesting happens in the labor market. So there's certain sector, so they have been hardly hit. So it's not difficult to imagine, right? Think about service sector. So and then think about testing and lockdown. So I'm saying lockdowns is easier to implement. So that's from the point of view of the government, because you don't need much technology, right? You just arbitrarily say, okay, so you just stay put, like what Chinese government do, right? But testing, so certainly you need have the technical support, and you need to have the resource, right? So apparently Indian, so the government is shorting of the testing techniques, but this is only on the surface. Now, if you think even further, right? So lockdown, as I just pointed out, so in the labor market, if you have lockdown, there's certain factor, certain sector, so the worker is going to affect him more than the other sector. And generically, maybe this is like a bold statement. Basically, if there's lockdown, so you can, in a crude way, essentially is a low-skilled worker, they pay the cost, but then high-skilled worker, they benefit. Right? This lockdown. And then test